Good afternoon, everybody, and welcome to the Children's Law Centre and to our webinar on Safe Minds, Safer Futures, Mental Health and the Youth Justice and Secure Care in Northern Ireland. My name is EMcN. I'm the Senior Solicitor at the Centre, and I'm joined today by Dr. Phil Anderson, who I'll introduce to yourselves in a few moments. So, just by way of scene setting, for those of you who don't know the Children's Law Centre, we are an independent charitable organisation which was established in 1997, and we use the law to try to promote and realise children's rights. Mental health in the justice and secure care settings is a priority for the Centre and has been for a number of years. And really, just like anybody else, children who interface with the youth justice and the secure care system have the right to the best mental health possible and should be supported to have positive mental health and well-being in all aspects of their lives. And these rights are enshrined in the United Nations Convention on the Rights of the Child, which is the principles upon which the Children's Law Centre are founded. Now, under the UNCRC, the UK government has promised to ensure that these rights are realised for all children, and includes a number of articles that are particularly relevant when we're talking about young people's mental health. Particularly important is the right to have the highest attainable standard of health and access to health care in Article 24. The right to a decent standard of living that allows a child to develop fully, physically, mentally and emotionally in Article 27. And children also have the right to receive information which helps to promote good mental health under Article 17. And importantly, the UNCRC is clear that all children should have their rights realised without discrimination of any kind. Now, the Department of Health has recognised that mental health illness is one of the most significant causes of ill health and disability in Northern Ireland, the other three being cardiovascular disease, respiratory disease and cancer. The Northern Ireland Audit Office reported in 2023 that Northern Ireland is the highest prevalence of mental ill health in the UK, indicating that it's 25% higher among adults than in England. It was said that this prevalence rate was associated with greater levels of deprivation and the legacy of Northern Ireland's history. But mental health, and specifically mental health for our young people, has been the Cinderella service for decades. CAM's current funding is approximately £20 to £25 million per year, and depending on which source you look for the information, that's between 6.5% and 8.5% of the total mental health budget. A report in 2023 by the Northern Ireland Audit Office estimated that the cost of mental ill health in Northern Ireland is around £3.4 billion annually. The report also suggested that financial pressures continue as mental health funding in Northern Ireland was the lowest in the UK. And the Audit Office noted that mental health funding had not kept pace with increases in the wider health budget over time and would require substantial investment to bring funding levels closer to the rest of the UK. It's an action within the current mental health strategy to increase the funding for child and adolescent mental health services to 10% of the adult mental health budget. However, this was a call back in 2007 in the Bamford Review, which suggested that at that stage it was doubled to about 10%. So we're almost 20 years later and still talking about that level of funding. The Young Youth Wellbeing Prevalence Survey from 2020 provides a picture of the extent of mental ill health amongst young people. It found that approximately 1 in 8 young people between 2 to 19 years old experienced emotional difficulties. 1 in 8 adolescents aged 11 to 19 years old reported thinking about or attempting suicide, and 1 in 10 reported self-harm. In 2023, the Office of the Mental Health Champion reported that 45% of 16-year-olds in Northern Ireland have probable mental ill health, with females reporting higher levels at 53% compared to 33% of males. But data on mental health must be treated with caution, because the Office for Statistics had a review on mental health statistics in Northern Ireland back in 2021 and found that there is a scarcity of robust data in relation to mental health in Northern Ireland, which has hindered the development of official statistics, meaning there are significant and fundamental data gaps. Issues with data collection are not unique to the health centre. The Audit Office also reported in 2019 that there's been a failure in the criminal justice system to collect good quality data on mental health and key vulnerabilities. Now, in May 2016, the Assembly passed the Mental Capacity Act, Prior to this, law on mental capacity had developed through case law. The Act came about as a result of recommendations made by the Boundary Review in 2007, which recommended placing mental capacity law on a statutory footing. Phase 1 was completed in 2019 and commenced the provisions of the Act in relation to deprivation of liberty for a person who lacks capacity. But the implementation of the Act has been painfully slow, and there's no indication really as to when the justice provisions of the Acts will be implemented. In evidence to the Justice Committee on the 13th of June 2024, the Director of Safer Communities at the Department of Justice said that the prevalence of mental health in the justice system is of increasing concern. However, poor mental health of those who come into contact with the criminal justice system is not a recent challenge. In 2010, the Criminal Justice Inspection for Northern Ireland reported that mental health presented enormous challenges for the criminal justice system. The Northern Ireland Audit Office has also reported that achieving the objectives of the criminal justice system has been complicated by the challenge of providing mental health services to the public. It found that many of the people with complex health and social needs who came into the criminal justice system had not been in contact with community health services because, amongst other things, funding for those services had not kept pace with demand, meaning people struggled to access the care they needed. Access to mental health services continues to be a factor, and wider problems facing health services have a knock-on effect in the criminal justice system. That's just by way of introduction, and we're joined today, I'm very glad to say, by Dr. Phil Anderson, who is a consultant forensic psychiatrist who works in the South Eastern Health and Social Care Trust for the Forensic Child and Adolescent Mental Health Service for Northern Ireland and the Acorn Therapeutic Service. Dr. Anderson is going to take us through his professional journey, discuss some current services, discuss complex needs and the legal interfaces in the system. There will be time for questions at the end, but please feel free to enter those into the question and answers box as we go. So without any further ado, I'll just hand you over to Dr. Anderson, and I'm going to share on your screen a copy of his slides, which will be available to everybody after the presentation today.
Thanks, Eamon, and Children's Law Centre for inviting me to do this webinar and what's really a passion project for me in terms of the intersection of all of young persons, normative adolescence, mental health, neurodevelopmental difficulties, and the law. So without further ado, if we just start the presentation, if you could put that on, Eamon.
It's up, first slide's on there.
We're having some technical difficulties, if I'm honest, so I'm relying on Eamon to good slide management here. So if we move to the we're on the first slide. So I'm, as Eamon said, I'm a consultant in child and adolescent forensic psychiatry, and I have a complicated work setup, but to be straightforward today, I'll say that I'm South Eastern Trust, which is in the case of normal working hours, out of working hours, I work for Beechcroft for Belfast Trust. So if we move to the next slide, so as Eamon has said, we're going to talk about the professional journey in chapter 1. I'm going to provide a bit more information about the two services I work predominantly for, which is the Regional Forensic CAM Service and Acorn Therapeutic and Mental Health Service. We're going to look at the population we're discussing, so this wider kind of youth justice, secure care environment population of adolescents. And then the complexity of their presentation meets the challenges and complexity of the law and some thoughts. So I suppose in terms of the fourth bit, in terms of legal interfaces, I want to maybe highlight some of the issues and some of the potential solutions. And with that, I mean, this is obviously a massive topic, but kind of set direction for perhaps some of the questions that are likely to come up. So if we can move to the next slide, please, slide number 3. So I have been on a very professional journey in my career, and fortunately it is kind of all come together and been complementary for the current post that I have. So if we move to the next slide. So I work, even within psychiatry, it's I guess really a standalone regional specialist post in 2 subspecialities. So that being child and adolescent psychiatry, so that's the assessment and treatment of mental health conditions in young persons. And then forensic psychiatry, so that is where mental health meets the criminal justice system essentially. So why persons are presenting with potentially serious public safety issues or find themselves within the justice system because of mental health conditions. And then with that, their forensic psychiatry has specific training on becoming an expert witness that I also do today, and I'll talk about in terms of the legal interfaces. Um, but prior to that, for the next slide, please, so we're on slide number 5, to illustrate the very journey that I've been on. I'm not sure if all the places above are familiar. I'd imagine one or two are, and certainly the two that give their names away. But I originally started my career in pediatrics, and that was always my intention and focus from school onwards. Um, but being within pediatrics, I developed a passion for child adolescent mental health. I was based with a now retired consultant psychiatrist, Hilary Boyd, that was based at the RBHSC. And that led me to switch paths, as it were, into psychiatry. But within psychiatry itself, the journey has been varied and I was going to say distinguished, but I don't think that's the right word. It certainly has been varied and complex. So I have worked in all of the secure facilities in the north of Ireland. And when I say that, what I mean is the big house in Moira, as well as Hydebank and the custodial facility in the northwest. I've also, in the top left, worked in Broadmoor High Secure Hospital. So part of forensic psychiatry training to become a consultant, you need to spend time in high secure hospital. That isn't available in the north of Ireland. And I've also spent time at Shannon Clinic, which is our highest level security in this part of the world, which is medium secure. So that's where the time I've spent the majority of my training. I've also unfortunately had to return there at times because we have no secure CAMHS hospital facility here. And I've had to have under 18s in what's an adult facility, and I've had to take consultant responsibilities under the mental health order for their care. So all of this, I guess, has really worked together as is my point to where it's brought me and my current input in terms of current services. So the next slide, please, Eamon. So I work in essentially two regional posts. One is regional actively in terms of it's across the 5 trusts. And then the other has young persons that come from all of the 5 trusts, but in a specific location and secure. And the 2 regional facilities, Woodlands JJC and Lakewood Regional Secure Care Centre in Bangor and County Down. So the next slide, please, Eamon, is so I am consultant psychiatrist and clinical lead for the regional forensic child and adolescent mental health service for Northern Ireland. So as I said, this is a regional specialist multidisciplinary CAMHS service. It's managed by Southeastern Trust and it's based in Newtonards, County Down. So this service was really commissioned to support local services, be they youth justice, social services, CAMHS, the local harmful sexual behaviour teams, manage and understand and care for young persons presenting with complex needs and significant public safety issues. So if we move to slide 8, so that's demonstrated on the next 2 slides. So the referral criteria is complex needs and a significant risk of serious harm to others. We also in this service, so we have no secure CAMHS hospital in Northern Ireland, so be that low or medium secure, we have to seek that by extra contractual referral, primarily to NHS England, although Scotland is in the process of establishing their own facility, but it's not yet operational. There are private providers of low secure CAMHS hospitals in Wales, but predominantly these facilities sit within England. So that's additional role we have as a service. So slide 9. So the public safety issues that have a wide presentation, but often the same root cause as I'll come back to. So typically aggression, interpersonal violence, but also harmful sexual behaviour, stalking, fire setting, animal cruelty, and increasingly violent extremism, which I have a slide on that I will come back to. We have a tiered service model according to the young person's needs and the services needs that are looking after them. So most of our cases are at advice and signposting. Level one would be liaison to risk management meeting chaired by another agency. Level two would be like a specialist violence risk assessment consultation, predominantly using the SABRI, Specialist Violence Risk Assessment tool that informs our risk formulations that then underpins care planning and risk management advice. And level three is really those young persons. It can be well understood, but it's usually the intensivity of their care supervision needs within the community that are very, very challenging to meet and need ongoing dynamic risk management meetings. So that would only ever be a very, very small number at the top that would require that. I suppose in terms of Site 11, it's not a static space is what I would highlight. Certainly in forensic cams in this new calendar year, and the first quarter and we're now deep into the second quarter, we have had our highest number of of young persons involved with safeguarding issues relating to violent extremism ever. We've had more in the last 2 quarters than we've had in. I have been in the service in totality from 2008 through to 2024. And this picture, unfortunately, is not out of keeping with what UK-wide data and in other European countries, such as Sweden and Norway, that there, since COVID, whatever went on with that as a phenomenon, that the number of under 18s who have been exploited in terms of the safeguarding issues relating to violent extremism is massively increased. There's been a huge uplift in the known data, and I brought that in. I mean, I could talk at length about each of the various problem behaviours, but I suppose that in itself has had a significant shift, and I suppose it's just illustrating, as I said, the dynamic nature of the space. Moving on to the regional facilities, so the top left is Woodlands Juvenile Justice Centre, so that's the under 18 custodial facilities. So that would be young persons as young as 10. We know, and Eamon's also very passionate about the very low minimum age of criminal responsibility within the North and how that unfavourably compares to other European countries. And then on the right, that's Lakewood Regional Secure Care Centre. So in comparison, that would be via the Secure Accommodation Order under the Children's Order, and admission there is determined in terms of bed space by the Regional Secure Panel, and then appropriate matters are sought in court to achieve that by a Secure Accommodation Order. So though, in terms of my other service, if we move on to the next slide, which is Acorn Therapeutic and Mental Health Service, in slide 13. So this is a relatively recently commissioned service, bringing together services that were based both in Woodlands Juvenile Justice Centre and Lakewood. And this was after a review of regional facilities in 2018. They made a number of recommendations, not least of which that health and education resources should be integrated within the two regional facilities. So I suppose the service functions, this would form all the typical roles of community CAM service, but also wider enhanced therapeutic support to the staff working with younger persons, similar to scaffold and TT-LAC services that are based in social services across the North. So I suppose that the primary clinical functions are the same in terms of clinical assessment, case coordination, the delivery and monitoring of therapeutic interventions. I suppose specifically and uniquely transition support from all the containment, safety and structure and routine of the secure environment, the often unpredictable and chaotic element for a lot of these young persons face in their lives in the community, and the consultative therapeutic support that I mentioned. There also, the review of regional facilities led to the creation of a unified integrated framework for therapeutic care and looked after children services. So the service is a key strategic role in delivering that, given it's a regional facility and which accepts kids from across the 5 trusts. So moving on to slide 14. So just to talk a bit about the complex needs of the space. So but I think to do that, you have to think about adolescence itself. So if we just move on to slide 15. So historically, neuroscientists and experts in the field would have, I guess, really looked to, birth to early childhood as the main period of brain development, and then not, the period after thereafter, relatively limited change. And there is aspects to that, obviously, with the growth of early childhood, not disputing that by any means, and the change in neural architecture and brain size and behaviors and all of those things. But what has become more apparent in the last, certainly from the late 1980s onwards, is that adolescence is a distinct period of brain development and functional changes in brain application over this period. And the arbitrary age of, sort of 10 to 18 in terms of the state just doesn't really equate with what the science would say. And it's probably something a lot more approximate of 12 to 24. And that's recognised in other countries like Australia, where CAM services go up to those kind of age parameters. And I suppose raises questions for me about, the Youth Justice Agency and working with young persons that are essentially in the same wider developmental frame of mind and functional brain use. But over this period, what we do know is that there is significant and profound changes in the brain architecture. It's a process called synaptic pruning, and I mean, in short, it leads to changes in what are different types of functional brain matter, so white matter and grey matter, and this changes rapidly over the adolescent period. And that's, I suppose, great in terms of the slide there and the chart. But what does this mean? I suppose people might be thinking. So if we move to the next slide, so in essence, there's really three main and significant and profound functional implications of what we know about the changes in the adolescent brain. So there's a huge predisposition towards taking risks versus safety, a preoccupation with peer influence, and hypersensitivity to social exclusion. So none of these aspects are pathological with adolescents. They're normative, and I think that's the key message: is that this is there is a different period, and maybe different approaches are needed. And I guess that is also seen in the next slide in 17. So this is the typical offending profile in population. I think this chart is from Australia, but this would equate with criminology studies, globally. So the predominant peak of crime is within that period, and that is really understood within those functional changes. And we need to, I suppose, recognize from a public health, position of the impact of violence and criminal activity meet adolescents at risk at the earliest point of their journey towards coming in contact with secure care or the justice system. It's also interestingly the peak time in which diagnosable mental health conditions appear, and the graph looks remarkably similar. And I suppose I'm just making the point again is that this is this distinct change in brain structure and the functional outworkings of that in adolescence. So if we move on to the next slide, so the normative changes in adolescence are not an abstract, because there's often a significant level of complex needs within this specific population of secure care and youth justice. So Sinn Féin and the Green Party have done a number of FOIs over the years about the number of young persons in within Woodlands, JJC, that have significant mental health difficulties. So this was 200 young persons over the last 3 years. I think this was the Green Party that made this FOI in particular. But that is I guess is really standard, and it's in keeping with established bodies of research elsewhere. If we move on to the next slide, so complex needs is often a term that's bandied about in the media and popular press, but it does have a definition with the House of Commons. There's a working group set up about this about 10 years ago. So it's two or more needs affecting mental, emotional, social, or physical well-being. And I tend to use this more actually than in a lot of reports and wider service development issues and discussion, because it's just it's a limitation of diagnostic categories. It's hard to really capture sometimes, and there's an element of family challenges and dysfunction and complex trauma that doesn't necessarily neatly fit within the diagnostic categories that the law wants in terms of black and white, in terms of my expert witness role. And what we do know, as I said, youth justice secure care populations have substantially higher levels of complex needs than the general pop. So we move on to slide 20. So unpacking this further and tunneling a bit further into this issue of the prevalence of complex needs, there is overwhelmingly these kids had experienced incredibly difficult lives, and also there's a diversity to the traumatic life experiences that they've had, and also it's not just about adverse childhood experiences; it's also about the absence of positive childhood experiences. So, um, in name, someone that loves you and cares about you and is invested in your well-being, and will say when you're putting yourself at danger, and support you when you need a good cry. All of those normative family things that many of us are fortunate enough to experience in our early lives growing up is absent for these kids. So it's the trauma and the absence of the positive care and supportive relationships is the key issue. If we move on to the next slide, please, Evan. So slide 21. So again, this is something that has had huge focus over, I guess, my particular sort of interest in space from high school onwards. So the sort of the early 1990s onwards, the impact of childhood trauma on global outcomes has been recognised to be profound. So the original study, this was on a population in San Diego, and they basically observed that adverse childhood experiences in aggregation can have profound impacts on global outcomes in terms of lung disease and cancer, in terms of suicide attempts, in terms of her educational outcomes, in terms of depression, early pregnancies, liver disease, IV drug misuse, but also in terms of the justice system. If you have experienced foreign war races, it's something like 15 times more likely to be a victim of violent crime, up to 20 times more likely to be in custody because of a violent crime. So there really are global aspects. I'm not going into the science of how this is understood, but it's just, I suppose, is the point that these young persons have often lived very different lives from what we have. And I suppose that in terms of if they're in contact with the youth justice system, I guess this is mitigation factors, but there's a reality to it and authenticity to it that I think the popular press often minimize, and it's a real problem in terms of that wider kind of media reporting of young persons within the justice system. But I mean, the impact, so that was the original study that led to the understanding of this in San Diego was huge. A huge number of young persons are involved. But in slide 22, there was another study that was done in the 2000s of the Florida youth justice population. It's a huge study. I think it was something like 15,000 young persons, which is probably reflective of the North American justice system. And I'll leave that comment there. But basically, the important thing that came out of this study was that there really is like a dose response relationship between recidivism and the number of ACEs. Really, really powerful when you see that on the chart I've displayed there. So trauma is one aspect of the complex needs. The other thing that I would focus on is neurodiversity prevalence in youth custody and secure care populations. So autism is completely off the charts. It's a multiple of what it is in the general population. If you look at any research base to this population, so it sits around 15%. Studies will indicate so that it's in around the 1% mark of general population. Speech and language disorders is potentially the highest, research will indicate. So this is expressive and receptive and mixed communication disorders. So it can be as high as 90% in some studies. And again, that's mostly in around the 1%, but some have put it as high as 7% in the general population. Similarly, intellectual disability, it's a multiple of what it is in the general population, somewhere in around a quarter of secure care youth justice populations at any one time. If we move to the next slide, in 2023, we published 5 years worth of data within the forensic CAM service in Northern Ireland, with our good friend Colm Walsh in QUB, one of the researchers in the criminology department there. And again, slide 25, this was very much in keeping with what was elsewhere and what we know about the space, very high rates of ASD, ADHD, and intellectual disability. And this is broadly in comparison with other studies done by other regional forensic CAMs and national services in NHS England and Wales. And I suppose overall I suppose that what I would be keen to communicate to body politic, and I guess the law doesn't have, courts don't have much say over the public health approaches, but there have been moves across the UK about developing public health approaches to problem behaviours and violent offending. And whilst there has been specific and notable moves with it of projects from ending the harm department within the Department of Justice, there still isn't a holistic cross-departmental, including health, public health approach to youth violence. And I think that this is incredibly important in terms of, all research indicates that addressing problem behaviours must look at the complex needs, including the health needs, in terms of improving global outcomes. And courts and the youth justice can't police or this matter on its own. We have to look at the root causes. And the biggest bang for your buck and the most effective approach is to work with families whose children are at risk, at the highest risk, and at the earliest point possible. And I don't think we have got that right yet in the north of Ireland. I think we've quite a journey in terms of cross-departmental approaches to this and understanding violence, including youth violence, as a public health issue. And this brings me on to the fourth chapter, legal interfaces. So, as I said at the beginning, part of my higher training and what I needed to demonstrate competency as a forensic psychiatry trainee was my ability to act as an expert witness to the court. So I currently continue to do that today in terms of what's particularly adolescent criminal and civil cases. But it is a challenging space, and I suppose for the legal members of our audience, the issue of legal aid and the availability of experts is causing significant issues. But probably more importantly, that I see it affecting the kids through my day job and the HSCT. And the incredibly long time it takes to get access to an expert in terms of moving on to the next stages of fitness to plead or whatever the particular court process or issue at play is. And if we just move on to the next slide, I suppose I was thinking in broad strokes to frame how some of the questions might come. So I suppose we have the unresolved legislation issues, and certainly on behalf of the Royal College of Psychiatrists, I've had a number of meetings with Children's Law Centre over recent years about the unresolved, what are essentially deprivation of liberty issues in essence, because that's ultimately what minimum age of criminal responsibility leads to. We have, at the age of 10 years, we have a woefully low age of criminal responsibility. And it really sits as I've contributed to Raise the Age campaign on a personal capacity. On an ethical basis, I just, it sits uncomfortably with me that kids, in terms of making decisions about the contraceptive pill or family decisions, and which is often done in a comfortable space with professional support, all the right information presented, that there's a real legislative disconnect between then a child who probably complex needs, adverse childhood experiences, out with another group of adolescents who, as we know from the slide about neuroanatomy changes in adolescence, they'll be preferentially exposed to than if they were, older adults, 30 plus. And they make decisions under the influence of alcohol and other substances to commit said crime. It just doesn't seem right that 10 is held as the minimum age of criminal responsibility in terms of criminal decision making, but it's much, much higher in relative terms for health and social care decisions. And we also have the issue of deprivation of liberty. We still the minimum age or the the legislation for dolls doesn't apply for the under 16, and declaratory relief order needs to be sought. There still is a lack of clarity in case law about the issue of 17-year-olds. Can parents, consent to their deprivation of liberty? And I suppose I'll ask the question: if EMcN doesn't, can the state make those? Does it have to, in terms of consenting to their deprivation of liberty, and whatever aspect that might be? We have really, really complex interfaces. The law loves the black and white, and that doesn't always neatly fit with diagnostic categories. There's the need for justice needs and public safety and the justice of the victims at times, and that needs to be, managed in concert with meeting the needs of the young persons who are often victims themselves of, as I've illustrated in previous slides, with a high, level of trauma and neurodiversity related issues. And the court and the justice system needs to be trauma informed and neurodiversity sensitive. And I suppose we might unpack that a bit more in questions. There's the availability of appropriate experts, and I say appropriate and bold because there seems to be a reluctance about other consultant psychiatrists stepping forward to be experts. There's context to that. The legal aid, again, I'm sure the legal professionals here are well aware of the challenges there. But there's case law in terms of the GMC versus Dr. Poole in 2014, which sets a really, really high threshold about what is an expert as defined by the law, which is as tight as the psychiatric subspecialty you belong to. So Dr. Poole was an intellectual disability consultant who acted in a general adult case and a civil case. And he was found to have acted as not an expert in the field that he was acting an expert in, and there was significant professional consequences for him. Also, immunity from being sued has been lifted in terms of experts. I think it was maybe actually an engineering case of a civil engineer that was an expert witness. I'd need to check that, but essentially then experts can be sued if they give inappropriate evidence, so that's also a deterrence. And then there's whole system resources, as Eamon illustrated at the start, the wait lists in terms of, or the funding to start off with in terms of CAMHS relative to the UK and the UK overall in terms of healthcare as per compared to other European countries. There are immensely long wait lists for neurodevelopmental assessments such as autism. The resources of the system are letting our children down, and often because they're not getting their clinical, therapeutic, social care needs met, they're invariably finding themselves in the justice system and secure care environments that they wouldn't otherwise have been in. So, and then also then providing that resources to court in terms of registered intermediaries and how that's all organised, and the recognition of complex needs within the youth justice system and secure care, and how young persons are best supported with that. So that, I suppose those are some of the current issues we might want to discuss today. I guess in terms of potential solutions, I'm very much an advocate of groups and societies and the voluntary agencies and professional groups as Royal Cause Psychiatrists in terms of advocating for change in terms of the minimum age of criminal responsibility, as we've done, and hopefully that campaign will pick up again. There's the real need to connect services in terms of the court services and I suppose particularly ACORN, Therapeutic and Mental Health Service, and your justice system. And overall, I suppose having trauma-informed and neurodiversity-sensitive approaches that, the way a young person might be presented in court is not necessarily indicative of guilt. And what often is, misunderstood as callous indifference is actually a function of their social communication difficulties and empathy difficulties in terms of their autism diagnosis. And that there is case law again around that being missed, and expert evidence being used to challenge some of the issues there. And then there's well managed use of court required resources. So, I mean, I think in terms of criminal cases within the youth justice system, I think they're very much, we need to consider use of single court appointed experts. And in context of the register or the high prevalence of neurodiversity in the court system, for me, it needs to be ruled out rather than reeled in terms of registered intermediary use. I suppose my HSCT job for both forensic CAMS and ACORN Therapeutic Mental Health Service, I'm constantly advocating to social workers to check that an RI has been organised for the young person in terms of police interview and then at court. So I suppose that Eamon brings us on to the third slide and the outro. And I suppose the point, this is a broad nexus to cover. It is a nexus in terms of the intersection of the law, in terms of complex needs, in terms of how Northern Ireland functions as a state, public health, etc., and the media. But I suppose the one thing I would like to communicate is that the challenges that these young persons face in terms of their lived experience, but also in terms of their rights today, in terms of legislation gaps that are there, the disconnects that are there, and supports to be able to engage with that system. And whilst the behaviour might be pathologized by popular media, and it's often communication about the emotional distress that they're experiencing and can't communicate, which is due to their very difficult lived experience. So the next time a child presents in whatever capacity we're there, I suppose that's the takeaway message about what are they communicating through these behaviours and what do they need. So I suppose that's where I'd like to probably finish, Eamon, on that thought before we maybe go to more structured and wider questions.
That's great. Thank you very much indeed, Dr. Anderson. We have a few questions in the chat. The first one is what do you think needs to be done or can be done in order to reduce the wait list for CAMS and other supports for young people?
I think that the funding, there needs to be parity in funding to start off with. I think that is parity with NHS England. Because as far as I understand, we have a younger population here than in terms of our under 18 population and higher overall population rates of mental health difficulties. So there has to be proper equitable funding that's needs based. And I know this is a challenging time in terms of the wider UK government and in terms of funding and what we're allocated here in the north as part of that. But that is key, I suppose, in terms of organisation. I think some of those steps are already there in terms of managed care network, in terms of benchmarking between the trusts, in terms of CAM services that are there, attention to quality, good screening of what comes in. But it's also, I think, about trying to meet the kids' needs at the earliest point, and it's the early in terms of Sure Start. Those families with infants that have very clearly emerging emotional and behavioural issues compared to other young children their age. And I think trying to meet that at the earliest stage is really crucial in terms of not only the waiting list, but overall long-term outcomes, because the impact of mental, emotional, social functioning is so profound on all outcomes: education, economic outcomes, relational outcomes. So I suppose that would be my key message.
Yeah, but tie in very much with the thinking that the centre has had. We have always harked back to what Bamford said back in 2007 about the level of funding that was available for CAMS. At that stage, it was 4.5% of the adult mental health budget, and Bamford had recommended immediately doubling it to 9. And the strategy for the mental health strategy is recommending 10%, which is probably not really in keeping with where it needs to be.
No.
The second question then would be in relation to MACR, or the minimum age of criminal responsibility. Again, this has been an issue for the Children's Law Centre for many years and been worked on through many various forums. But we have the issue, as you've said in your presentation, about 10 being the minimum age of criminal responsibility. We have a Mental Capacity Act, which has taken forever to really be implemented, which suggests that 16 is the age at which we would have capacity. How do we square the circle then between all the various different, and there may be no answer to this, how do we square the circle to all the different ages that are put on
Yes.
capacity or competency for young people?
Well, I suppose my personal view, and not that of my employer or the Royal College of Psychiatrists, is that um, that I think there should be a unified minimum age of capacity for all of health, social care, criminal decision making, and we need to agree what that is. I mean, if it's 16, as I said, if you want to make a decision about an important healthcare decision or intervention, that you're sat in an appropriate room with professional support in terms of the medical staff, probably given refreshments, you're given time to think over the information. Whereas that's a very different context to a 10-year-old with no family support and other in the company of other adolescent peers involved in that type of activity and alcohol and other potentially similar substances clouding judgment, which is a common picture that we would see in Acorn. So for me, that the ethical position for me is that there has to be a unified minimum age of capacity for all decision making. I suppose the complexity in it is when a person presents with that below that age and how that's worked out. Obviously, Gaelic competence still sits in case law, and how that's worked into the new capacity legislation and the under 16s that are left. My view, were really left abandoned by the new legislation coming in. They weren't. I don't know what the views of the department were and how we got to this situation that the under 16s aren't fully embraced, for want of a better word, in terms of the act. So that would be my view.
Yeah. To sort of paraphrase back in the day, or to sum it up in the day, way back in 2012, the children's sector were told essentially not to worry about the under 16s, that there would be a separate project to look at the emerging capacity of under 16s that would run at the same time as the Capacity Act. And as far as I'm aware, 13 years later, it has never had pen to paper. So that was really what we were told to expect as the way forward. Another question has come in here. Is Dr. Anderson aware of any other consultant psychiatrists based in Northern Ireland preparing expert reports in criminal cases? Or is there a database, or is there somewhere people can access information on who's carrying out such reports?
I always thought it would be a great business idea if there was an Uber app for expert witnesses that the legal professionals were able to use. But no, that doesn't currently exist. What some do is try to contact the Royal College, but I suppose it's not really a function of the Royal College, but they do send emails around at various times out of goodwill. I am, to the best of my knowledge, currently the only child adolescent forensic consultant on the island of Ireland. They were looking at setting up a similar service in the south, but it's I think currently it would be sort of equivalent to Acorn rather than forensic cams as such. So it is a unique space to be in, which is challenging and isolating for me as a professional. Not least of which the challenges the court has, and I think the GMC versus Dr. Paul Rowland has probably made adult forensic consultants very reluctant about stepping into under 18 expert witness work because of the professional consequences. The Royal College has a document published that online, so that it's helpful to reference in terms of looking for expert witnesses. But I mean, my understanding is information is having to be sought from, or expert witnesses having been sought from England, Scotland, and Wales to be able to achieve this currently. And it's difficult because if I have done that for the PPS, then the difficulties of trying to get someone for the defence can be really challenging, or vice versa. Um,
One of the things that you had mentioned in your presentation was about the fact that we don't have a full function forensic CAMS unit in Northern Ireland, and the need to send young people to England or Scotland on an ECR.
yeah.
Are there many young people sent out each year, and do we require our own unit?
So it's a complex issue. So low secure camps. So that's essentially young persons that are predominantly risk to self, maybe some lower level aggression that can't be managed in an open unit. So admissions tend to be as long as 12 to 18 months, which is significantly different from Beechcroft, which is the local acute CAMS unit, where even in the PICU, it's really up to about 6 weeks or so. There are longer than that, of course, but on average, it's a few weeks compared to, almost a couple of years. And medium secure, so that's young persons that, alongside their other safeguarding issues, pose significant public safety issues. So similarly, long admission times of 2 to 3 years on average. So yes, so we've none of those in Northern Ireland currently. Scotland are in the process of establishing their own facility. There's quite a number, mostly within England and Wales. There's a couple of independent providers, but no NHS Wales providers of secure campus hospital. In the south, they have a facility built in Portrand, just outside of Malahide. I think, to be honest, that this is really similar to cardiothoracic surgery, is best organised on an all Ireland level in terms of, if families from the north were able to access that, it's pretty much on the train line. That would be, again, not the views of my employer or the SPPG or called the Psychiatrist, but that I think that probably to me makes best sense, because you're talking about low volume, but like when their young persons are in our regional facilities that aren't commissioned suitable or safe to meet these young persons' particular set of needs, it's incredibly challenging. And as I said, like I have had to manage some young persons in Shannon Clinic, which is not a preferable situation to be in, either for the patient or for me as a consultant, and all the various safeguarding issues that might arise out of that. But the challenge, obviously, politics is always an issue, but there is precedent with cardiothoracic services being shared between the north and the south. The other issue is legislative change. So there's no reciprocal aspect in the Irish mental health legislation that allows the patients to transfer under the Norse mental health legislation. So in Scotland and that mental health legislation in England, Wales, there's a reciprocal part that allows for transfer of detained patient. That's not there. So that would need legislative change in the Assembly and Dáil, and that's obviously a major challenge. But in the distant future, that would be my preferred option. I think that makes most sense for young persons, their families, and the state here.
Well, that's it for questions on the chat, and it just remains me to thank Dr. Anderson on behalf of the Children's Law Centre and to thank all of you for attending online. The presentation will be made available digitally. Paul will send that out to everybody along with an evaluation form. So thank you very much, everybody, and thank you, Dr. Anderson, and
Thank
we'll see you again, I hope, and we'll
you.
just end the meeting for everybody. Thank you very much, everybody. Goodbye.